New markers. I will discuss 5, because that's, I think, the body of markers that's currently being used. I've done studies with 4 of them, and I was asked this week in the US to do a study with number 5, which is not still available in Europe. The bloody APA check test. It's also a test where you use 10 mL of urine. It has 50 proprietary DNA methylation markers, not the 15 best ones, but the 15 most complementary ones. It gives you a score between 0 and 100, and the cutoff is 60. If it's over 60, it's positive. In EUC of this test, the negative predictive value is high, certainly for non-high-grade tumors. So this is really something that could be used. Another test used in the US a lot, expert bladder cancer monitor test, 5 microRNA targets, and you put the urine in a small container, and this machinery, that's the funny thing, is available in a lot of laboratories, because you can also test infections and all kinds of stuff you can test with those kits, and they have a special kit for urine. And again, also this test does very well, and has a very good negative predictive value. Apparently, it's not accepting the next slide. Here you see negative predictive value again, very, very high, 95, 97%. Now, Hugo already showed you a small video, and I saw a little bit below you had a nice music video, which is also nice. Could have shown that too. Yeah. I've done the test with that, we've done a study with that. It's very convenient. You just have the urine, well, he showed you the video, so it's really not very difficult. Everybody can do that, even Dutch people. The preclinical part, Hugo explained it already. We started off with 2 mutations and some preclinical work that has been validated, and there was a very high sensitivity and a very high specificity, so that originally looked well. And then we did, that's the one I'm going to show you, a study in patients predicting whether they had tumor, yes or no. So it's a urine test. We performed that in patients that we know, so we're in follow-up for bladder cancer recurrence. We did that around 1.5 years in the Netherlands. And they all underwent, of course, also standard of care, cytology and cystoscopy. And you see here that the negative predictive value of the test was 95.3%, which is very good. And if you compare that to negative predictive value of cytology, that was 68%. So it's really much better. So conclusion with this high negative predictive value, so that's the patient. If the test is negative, he doesn't have a tumor, that's great, doesn't have to come. The test is really very useful. There is another test, CX Better. That's not used in Europe. They contacted me whether I would like to do a test with that. Again, negative predictive value, very high. And the 8x Better test, also used in Europe. Again, a very high negative predictive value. So these tests might really have impact on what we're going to do in the near future. And this is a review from this year. And if you look very well, that's what it is. Your monitor comes out best in all aspects: sensitivity, specificity, positive predictive value, and negative predictive value. You see it's everywhere on the right side. And in this case, on the right side is being the best. So you do have a very good test in that. And you see here, proteins, microRNAs, or DNAs. They're all those epigenetic markers. Very good to make a picture. So I think the conclusion of urinary marker tests, the older ones I told about you, are not widely used anymore because of cost issues, practical aspects, insufficient sensitivity, insufficient specificity. In follow-up, a test with a high negative predictive value, certainly for high-risk tumors, may result in less cystoscopies. And like I told you, I think these tests do better than my eye. A follow-up test with high specificity will result in only a few unnecessary cystos. But remember, otherwise that patient would have come in for a cysto anyway. So no harm done. An alternating cystoscopy with cytology with a new test could reduce the current diagnostic burden.